And you also like to count posterior ribs at certain times, so let's count them on the left. And 1 and 2 are very near. Do you realize 1 and 2, they are overlapping, and there's a tendency to call it 1 and call this 3, but then the counting would be wrong. 1 and second is going lateral, isn't it? So 1 and 2, then we come back to midline 3, 4, 5, 6, 7, 8, 9, 10, and 11. 12th is below. So in this case, they are 7 anterior and 11 posterior. And what is required is 6 anterior and 10 posterior. That is what is making the film inspiratory effort on the film adequate. Okay, and this is a Lodotic view. So you can't get rid of the ribs, but clavicle, you can have it shifted up. Can you see the clavicle has gone up? In the previous image, you saw the clavicle was overlapping some of the apex. I can show it again. So this clavicle, we can get rid of it. So this, do you agree that part of the apex, almost half, is obscured by it? Yes. So which disease is very common in the upper lungs? Any idea? In the apex, do you know TB likes to be in the apex? And there is a reason for it. Why? TB organism likes to have more air. It's aerophilic. So it wants more air and less blood. So when a person is erect, less blood goes to the apex. So early TB can be in the apex, and by doing a Lodotic view, you see the apex better. So that's a Lodotic view. Can you see the clavicles have gone up? So the person inclines backwards, clavicle goes up, and if it goes up enough, the apices of the lung are free of the clavicles. So you can try it at home. You can incline backwards and see your clavicle will go up, and the apex on the X-ray will be free of the clavicle. Okay, as long as you have a systematic approach, you can follow any pattern. So you have to see all of it. Bone and soft tissues, the abdomen which is visible, you have to look at it. Heart, you have to see mediastinum, aorta, trachea. Hyla is plural of hilum. Pulmonary vessels, we call them vasculature, lungs and pleura. So as long as you see all of it, it's okay. You can have your own approach. You can start from pleura and lungs, and go to the bone and soft tissues at the end. So one is called inside out, start from the heart, look at the lungs and the skeleton at the end. And outside in would be, you would start from the skeleton, look at the lungs and heart at the end. So one is outside in, other is inside out. But remember to look at everything. You can have any approach, but if you sort of complete this checklist and cover all of it, it's enough. Another sequence for reading is detect. So find out what is abnormal, then describe it. So these are called 5 Ds. Give a differential diagnosis, discuss the differential diagnosis. The purpose of discuss is to narrow down the differential and then come to a single diagnosis. So I'll give you an example of fever. So you detect fever by a thermometer maybe. So you record the fever, that is detect. Then you describe the fever. Describing would be, is it high grade fever or low grade fever? So that would be describing the fever. Is it more in the morning or in the night? So that is description. Then you'll give a differential diagnosis. That could be tuberculosis or bacterial pneumonia or malaria or something. So you have a longer list, or maybe 4 or 5 things. So that would be a differential diagnosis. Then you would discuss the differential. Now you would be using the describe part. So in the description, if you said that fever is low grade of a month, then is TB more likely or a bacterial pneumonia? TB has fever for a longer duration and it is usually low grade, especially to start with. It could become higher, but history is typically in weeks, 1 week or 2 weeks, or sometimes fever for a month even. And if it is high grade fever for 1 day, then is TB more likely or pneumonia? Yes, so now you have understood. So this is how the sequence you follow. You detect what is abnormal, you describe the abnormality, the features, when it happens, and you come up with a differential diagnosis, narrow down the differential by discussion, and preferably have a single diagnosis or at least a shorter list. So if you had a list of 5, if you come down to 2, you could do certain laboratory tests to further come down to the final or the single diagnosis. And remember, every X-ray has everything superimposed. So as I said, until we have 3D available, we'll have to live with everything superimposed over the other. A CT scan can separate out, as you can see on the right. So you can see CT scan can focus on the vessels, and you would call it a CT angiogram. It can focus on the skeleton and eliminate the rest. It can show you the soft tissues like it's showing here. So everything is superimposed on an X-ray, but a CT scan can separately show the various parts, the various structures. They can be separated out by a CT scan. So it will be clarified on the images, but for complete list, primary tuberculosis is usually seen in children, and it's also called a primary complex. Have you heard of these terms which are here? Has anyone heard about primary complex? Okay, so I'll explain it when the image comes. Miliary TB, anyone heard? Okay, so it's good you know one. And secondary pulmonary tuberculosis is also called after the primary when you get TB. Tuberculous pleuritis is which organ? Yes, so if the pleura is involved, it's tuberculous pleuritis, and extrapulmonary tuberculosis is TB anywhere other than the lungs. Yes. I'll come to them in the images. It's in adults. Primary is in children or adolescents, and if it happens afterwards, it's secondary in adults or in older age. And so TB can affect a large number of organs, but lungs are the most common affected. So lung is most commonly the affected organ, but you can see from the image that a large number of organs can be affected. Almost everything is here. It could be genitourinary, it could be skeletal TB, it could be CNS TB by affecting the brain. So TB is everywhere, but most common site remains the lung. So pulmonary TB in children, you will get primary complex. So primary, it's the first exposure, and there's a gone focus and a complex. So you have to wait for the image for it. Local infection and lymph node enlarged. Rank complex is when the lymph node becomes calcified, and this is a healed infection, and it is often asymptomatic, so it can be discovered by chance. There aren't many symptoms of it. And primary TB lymph nodes, which are very common in children, they are uncommon in adults. Pleural effusion without lung disease is also common in primary TB. So if anyone has to have TB, the best one is to have pleura affected, because once the effusion is, with treatment the effusion is gone, the X-rays return to normal. And if they don't return to normal, then for lifelong you have some signs of telltale signs which tell everyone that you have had TB. So if someone has had TB Middle East doesn't allow you to even enter. So, and the other countries, they do a workup for active TB, including blood, ESR, they look at ESR, they look at other evidence. So, a lot of workup is done. But if someone has had a pleural effusion, that can be cured and there's no sign left usually. Progressive TB, if it does not improve or get treated, then it keeps on increasing. More and more of the lung is affected, cavities are formed, and it may closely resemble post-primary TB. So this is the course less often followed, which is progressive. Usually there is an episode and there is recovery with or without treatment. So can you see there's arrow showing you a lymph node? Isn't this the hilum? Hilum is where structures enter or leave the organ. So this is the right hilum. Is there a difference between these two?
Yes.
Isn't this big? Yes. Isn't there some lobulation in it here? No. So it's big, it is lobulated, so it's a hilar, enlarged hilar lymph node. Normal lymph nodes are not visible. The same way we have a lot of lymph nodes in our neck, but they are not palpable. But once they are affected or there's some disease, then they become palpable. Have you ever seen lymph nodes in the neck? Some are even protruding beyond into the skin. So this would be a hilar lymph node enlarged. Can you see area of consolidation here? This is normal. You always have the two sides to compare, except for a few entities. Most of the things, they are one-sided. So can you see infection here? So this is a gone focus, and along with its lymph node, it becomes a gone complex. So complex is usually more than one thing. So consolidation or mnemonic patch in the lung, gone focus, and along with its lymph node, it's a complex. It is called a primary complex, and it is also called a gone complex. Understood? Especially who was asking. A gone focus, primary complex. Okay, so primary complexes, first of all, the lungs are infected. So you have a focus here. By the passage of time, the lymph node which drains this part, which is usually in the hilum, becomes big. And lymph nodes, even when they become big, they remain slightly lobulated. So can you see the lobulation here? So this and this together forms a complex, which is a primary complex. This is a focus, and along with the lymph node, it becomes a complex. Okay, so primary complex, another example. So now I would like you to tell where is it? Right, left?
Right.
And is any hilum enlarged?
Yes.
Which one?
Right.
Yes. So this is a second example, and where is the infection? Is it this? So that is the gone focus, and that is the lymph node, so it becomes a complex. So you have just practiced a case. Is it clear now, primary complex? This is the second example. That was on the left, this is on the right. And that is a close-up view. So you can also see it shows better. Focus and enlarged lymph node, and put together it's a complex. Okay, so post-primary is reactivation of this, reactivation or reinfection. Both can cause post-primary. So if it remains latent, latent is inactive. So if primary TB remains inactive and then it can activate later on, you would call it post-primary. Cavities are very common in post-primary. And you have poorly defined consolidation. Cavities are seen in 1/5 to maybe half of the total. Lymphadenopathy and effusions. Do you remember these two are very common in children? Lymph nodes and pleural effusion. But in adults, they are uncommon. And miliary spread can happen because if it is untreated, any TB can become miliary. Miliary spread occurs due to spread through the blood, hematogenous spread. And then there's always a question, active TB or inactive. So serial X-rays are the best. If you do an X-ray and repeat it in a month's time or maybe 3 to 4 weeks, if the consolidation or the infection is increasing, then you see that if it involved a small area, now it's involving a larger area. So serial X-rays are the best thing. Pleural effusion would make TB active because it's causing fluid to be produced, so there is active infection, otherwise fluid won't be produced. Endobronchial spread is from the bronchus into trachea, and it would go to other parts of the same or the other lung. Miliary pattern, cavities which have air fluid level. So cavity alone may remain for the rest of the life. It could be an old healed cavity, but if it has air fluid level, it's an active cavity. HRCT, we have tree in bud opacities. That is an appearance on CT scan only. And inactive, so pathology says over a period of 6 months, if you get 3 negative sputum, then you can label it as inactive. You repeat sputum for AFB or acid fast bacillus for 6 months, and if there is stability, so doing 3 X-rays in 6 months, and if there is no change, TB is inactive. Calcification is a sign of healing. So anything that gets calcified is healed. Bronchiectasis and linear opacities may be seen. So I'll show you example of bronchiectasis.